Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hi, I'm Dr. Michael Blaha, professor of cardiology and epidemiology and a clinical researcher at the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease in Baltimore, Maryland. Welcome to this program entitled Personalizing Risk Assessment to Enhance Cardiovascular Prevention, Quickfire Countdown with Imaging Experts. And joining me today is my colleague and friend, Dr. Chuck Vega, clinical professor of family medicine at the UC Irvine School of Medicine and assistant dean at the UC Irvine School of Medicine in Irvine, California. For this rapid fire program, one of us will pose a question about contemporary imaging modalities and how they improve cardiovascular risk assessment, and the other will have up to 2 minutes to respond. So let's get started with this format. First, risk assessment. Dr. Vega, why do we need imaging-based risk assessment when we have the prevent risk equations?
Well, first of all, thanks for having me. I'll try to keep my answers very rapid fire. Prevent equations are great. Those kinds of equations, they're evidence-based. They put us in the ballpark in terms of a patient's cardiovascular risk, but it doesn't give us the be all and end all. In fact, really nothing does. Patients might need more information, particularly if they're at a cusp of either being more of a moderate risk or no risk. In those intermediate categories, imaging could be valuable in pushing us one way or the other in terms of thinking about more aggressive therapy, lipid lowering therapy, aspirin therapy, and those could make a big difference for patients' cardiovascular risk over time. So obviously it is very important. So maybe you could go into one of the primary modalities we use, cardiac CT imaging, and getting a coronary calcium score. What is that, and how does that play into our clinical picture?
Yeah, great question. Yeah, because our new cholesterol guidelines are out, right? And they've set us up to start with those prevent risk equations. And they said, well, if you're in the borderline or intermediate risk zone, there's a class 1 indication to consider a calcium score as a decision aid in, like you said, the decision about lipid lowering therapy and aspirin, I would add as well. So the calcium score is a cardiac CT scan. It's a cardiac gated non-contrast CT scan, very rapid test, only about 5 minutes to do this test. Low radiation, about 1 millisievert of radiation, and generally an inexpensive test. It gives you that quick picture of the heart to see if there's calcium in the arteries. And calcium in the arteries means plaque. And the more calcium you have, the more plaque you have. So this is a test of total plaque burden that we use for risk assessment. And of course, risk assessment is the foundation of clinical risk discussions and shared decision making. So we use things like the calcium score to say, well, how high risk are you? Are you at high enough risk to benefit from something like a statin, aggressive lipid lowering therapy, lower LDL goals, or an aspirin? Or maybe are you not so much at risk and lifestyle would be the only or the primary modality for you at this time? So that's how we use the calcium score in practice, as well as in these new guidelines.
Well, let me follow up with another question because I've looked at the guidelines too. They're excellent. I think they're fairly succinct, and they do really give a good discussion as to the benefits and potential drawbacks of using coronary CT imaging. But there's also carotid ultrasound, which aren't mentioned as much in those guidelines. Could you cover carotid ultrasound and its role in terms of assessing patients' risk?
Yeah, that's a good point. So carotid ultrasound is an alternative to calcium scoring. It gets a lower, certainly level of evidence in our guidelines, but around the world, some places favor the use of carotid ultrasound over calcium scoring based on, I don't know, availability, for example, of the tools. An advantage of the carotid ultrasound is it involves no radiation at all. And it can be done even in the modern era at the point of care by the clinician. If you're trained to do point of care ultrasound, you can make a rapid bedside assessment of carotid plaque. So that's coming in the future. We might more routinely, as part of our physical exam, assess for carotid plaque. But the principle is the same, of course, right? If you have no plaque, you're relatively lower risk. If you have more plaque, in other words, plaque in more segments of the carotid artery on both sides of the body, then you're higher risk. So nowadays, we like to evaluate the carotid ultrasound using a carotid plaque score. The more segments involved with plaque, the higher the score, the more the risk. So once again, a decision aid saying, well, am I high enough risk to benefit from the more aggressive preventive therapies? So, okay, we define the carotid ultrasound, the calcium score, what they do. So, who, Dr. Vega, do you think are the best patients for these tests?
Right. First of all, I find that I don't usually have patients in that borderline range where I'm really like, gosh, I wish I needed a risk enhancer to try to give me some more information, either positive or negative, that pushes patients one way or the other. A lot of my patients have type 2 diabetes and chronic kidney disease. And so it's clear that they need not only statins, it's probably high intensity statins for them. And we are going to talk about aspirin therapy, particularly if they're under 60 years of age. But there certainly are patients, younger patients fall in this category more often of a borderline risk. I think that the prevent calculator, just to go back to it real fast, has been a really successful intervention. We know it was developed, I think, with a broader, diverse cohort, a larger number of patients overall, and it accounts for important factors like the albumin creatinine ratio, like social deprivation. So you can add those into the calculator and makes it stronger. And we know it's already reducing the number of folks considered at significant risk for coronary disease. The new recommendations also call for the use of LP little a measurement. Those are things that are readily available to my practice, which I can use to get further risk assessment on patients beyond the prevent calculator. So at the end of the day, though, there are some patients that I can't tell them very strongly one way or the other where to go with lipid lowering therapy, particularly with statins. And for those patients, I do think about CT as a primary means to give them the best type of differential. And so there's been research that shows that coronary calcium scores are either pushing them into that moderate risk category or that low risk category. So I think it does have a utility for really many, many individuals who are younger adults and middle-aged adults.
Let's move to a clinical vignette. We got to bring this to the bedside. 52-year-old man with intermediate 10-year ASCVD risk by the prevent equations of 8%. Person's a non-smoker, has borderline LDL cholesterol values. This is something we see every day. So let's talk about this case. What do you think?
Well, I think I would want to get a little bit more history. So if this patient has a strong family history of particularly of premature cardiovascular events, then it'd be a no-brainer. Let's move them into that. That would increase their risk, and I would really recommend a statin. Using other lab work like an LP(a), if that was elevated, I would again move them into a statin category. And with an 8%, that's squarely in the intermediate risk range using the prevent calculator. So I would be thinking about using a moderate intensity statin regimen. But if that patient is resistant, and we certainly see lots of reasons for resistance, we know that getting imaging and getting a positive imaging study, whether it's coronary artery calcium or whether it's carotid ultrasound, could be helpful in convincing them to take a statin. So that's another tool we use, not so much in terms of my decision making, but more in terms of convincing the patient, because at the end of the day, they're the ones who are going to carry out this choice. Here's a scenario for you. Say that CAC comes back 0, but you still have an intermediate risk. What would be your next step, Mike?
That's a great question. I mean, because, right, you get one of these tests and you could get back results that vary from 0 to very, very high, right? So if this person, like you mentioned, the prevent is already 8%, it's pretty on the higher end. If the calcium score came back 0, then we move to there's other things mentioned in the guidelines that would still push us towards statin therapy. That's active smoking, that's diabetes, that's a family history of premature coronary disease in particular. So, like you said, it really comes back to the history. This person endorsed a strong family history of premature coronary disease. Of course, that familial hypercholesterolemia or diabetes, or certainly a combination of those, which maybe led to that higher prevent score. We're going to be using a statin anyway. But a key thing about the new cholesterol guidelines is they also talk about treatment intensification based on the calcium score as well. So with the calcium score, if it was 0, I probably would start on a moderate intensity statin and stop. But if that calcium score came back really elevated, it said if the score is above 100 or it's above 300, for example, we're going to shoot for an LDL less than 70 or an LDL less than 55. So the calcium score still might inform my use of intensity of statin therapy or add-on cholesterol therapy to get to goal. So really, it varies. It depends on who this patient is, what the score results are, and then a shared decision making about how aggressive to be with preventative therapy. So let's say the calcium score was above 100. Maybe let's say it's above 400. What about the decision about aspirin?
Thanks for making it easier on me because aspirin is one of those things that really does require shared decision making as primary prevention in every case. And we know that as you get older, your risk of having major bleeds just goes up. Even on an aspirin of 81 milligrams a day, we always want to be conscious of that. There is a risk of major bleeding associated with it. But when you combine that intermediate risk calculator with a very high CAC score, yeah, aspirin should certainly be on the table because he might actually have a risk that's more in that high risk category, or even to the level where he's already had a cardiovascular event, given the CAC score and his risk. So aspirin could be a good choice. Um, it really comes down to the patient responds. Maybe they have strong feelings about taking aspirin, but they don't want a statin or vice versa. Again, having imaging studies to back up our recommendations tends to increase adherence to things like lipid lowering therapies. Any pearls you have from your side, Mike, on this issue?
Yes, certainly. I think it's like you said, it's about how you talk to the patient about the results, right? If the calcium score came back zero, we'd say there's no detectable plaque right now, but here are your other risk factors like the family history. More importantly, when the calcium score, let's say, came back really elevated, it's important the way you talk to the patient about what the finding means, right? In many cases, I like to show the patient the images and even say, that's plaque in your arteries right there. That's the rationale why we're trying to be so aggressive here. And there's some literature that suggests when you show a patient their images or explain the idea of subclinical atherosclerosis, they're more likely to stick with their medicines.
One additional thing that I'd consider here would be with the CAC score being elevated in this 52-year-old individual with a moderate cardiovascular risk per prevent. If it's significantly elevated, you might think about not only pushing us more toward lipid lowering therapy, he might be moving more towards a high intensity statin as well. So that's something to consider in addition. And I use high intensity statin therapy routinely. The great thing is with either a drug like rosuvastatin or atorvastatin, we're able to move up the scale, and generally patients will tolerate that starting dose, whether it's at that moderate potency or the higher potency. I'll just start them off on a higher potency.
Yeah, that's a great point. It's really worth reiterating those guidelines that push for when the calcium score is above 100 or above the 75th percentile, LDL less than 70. When the calcium score is above 300, and certainly when it's above 1,000, we want an LDL less than 55. It's blending those concepts a little bit based on the amount of disease in the arteries. Okay, so moving into our last segment here, what are some practical considerations, Chuck, in your practice to consider when you're considering ordering or not ordering a cardiovascular imaging test?
Well, that's a great question because I am very much a pragmatist. So, unfortunately, I don't always have either ultrasound or CT imaging available for patients. I can't order it because patients are going to pay out of pocket. Medicaid and Medicare coverage, which is my practice, is pretty spotty for covering those modalities. It is not incredibly expensive if you're paying out of pocket, but that's untenable for my patients, unfortunately. And that's why I kind of go back to history, taking a family history, looking at any history of smoking during their lifetime, and then using things like LP Little A could be a good differentiator as well. So imaging is great. We know, as I said, that it is really the top way to move somebody from a borderline risk into either into a statin therapy or into no statin therapy. But it's not always available. But we do have those other tools at our disposal. Don't give up. The guidelines really focus more on CT versus ultrasound. And so I don't know if you have a preference in one of those two modalities from your practice, Mike, which is different. You're a specialist working in this area in a specialty center.
Right. That's a great question. Yeah, if where I practice, definitely the calcium score is what's preferred if we choose to go down the imaging pathway. Calcium score is now broadly available because it can be done on any multi-detector CT. So as long as you have CT imaging in your area, the calcium score can be done. And in our area, we have full access to calcium scores at about $75 for our patients. Most patients are able to get the test, but still, it's part of a discussion with the patient. Maybe you're borderline to intermediate risk. I'm thinking about heading one direction or another, but this would be an option to be more certain about our decision, maybe help you understand why we're making this decision. So I tend to get a lot of calcium scores in my practice. Once again, they're broadly accessible, they're inexpensive. I like how they're numerical they are. They come out with a score that can rapidly be translated into guidelines. And you can see because of that score, how should I treat the patient? And we've talked about statins and aspirin in particular. When the calcium score is positive, You think about a statin, and the more positive it is, the lower the LDL goal. And generally speaking, when the calcium score is above 100, we think about an aspirin. So I like that, but I understand that around the world, other people favor carotid ultrasound, mainly for reasons of convenience. But in the guidelines, in the new cholesterol guidelines, it does give the calcium score a class 1 indication in that decision aid. The carotid ultrasound is not recommended as highly.
So I just want to mention one other issue for the frugal pragmatists out there. The new guidelines from the ACCHA and a number of different organizations regarding lipid management, cardiovascular risk assessment do mention that if you have a previous CT that shows coronary calcium, not on a specific exam, maybe they were in for a trauma or they're getting lung cancer screening. When we witness coronary calcium, it's real. So that can be considered. It's not as complete as a CAC score, but for patients who have no other way to get that imaging done, just having that discussion again, saying, by the way, your lung scan was negative for cancer, but they did see that you had multiple calcifications in your major arteries.
This, no question, this incidental calcification is new. It's something we should all be engaging in, especially at older age. Up to 1 in 5 of our patients has had a prior CT scan of their chest for various reasons. So this is free information in the medical record that we should become more comfortable looking at. It's something we do every day in our practice. I skip ordering a calcium score routinely when I already have the information as a cardiologist in the chart. So that's a great one. Chuck, I want to hit this back to you. So what are some pitfalls? Let's say we decide to do an imaging test. What are things we need to be careful about?
I think the main thing is that a score of 0 doesn't mean that you have 0 cardiovascular risk. When a patient has a very strong family history of premature CVD, when they are smoking, we know that those individuals still have an elevated cardiovascular risk despite having a CAC score of 0. I still want to talk about lifestyle issues where may not initiate therapy, and then I don't let them go forever. We're going to want to recheck their cardiovascular risk within the next 3 to 5 years.
And one more thing I want to add to that is one pitfall we do want to avoid. These imaging tests are used for risk stratification and to guide preventive therapy. They shouldn't be used to guide an interventional approach. The calcium score comes back high, the carotid plaque score is high. Therefore, do we need a stress test or cardiac catheterization, or do we need a carotid endarterectomy, right? Those aren't the reasons we're using these tests. We're using them just to characterize risk, to guide medical therapy, to reinforce adherence to medical therapy. So we don't want to go down that pathway of doing additional testing in truly asymptomatic patients. That's something that comes up, and I see a mistake made from time to time by practitioners as well.
So I'll just take a moment to summarize. Use the Prevent calculator routinely for everybody. All adults really should get it. Now it goes down to age 30, so you can get that assessment. There were so many patients previously who were 33 and we really want to know more about their cardiovascular risk, and with pool corridor equations, we didn't have as much to show them. Now we do. For patients in that borderline category, do think about CAC or carotid ultrasound because they can tell you some very practical, objective information that can help you have a more informed decision-making process with your patients. And I find it more of a convincer for patients to take these therapies, which many patients come in, they're set automatically on less likely to take them, and it helps you move to more likely to take them. That's where I want a lot of my patients to be, working in a community with high social deprivation, high cardiovascular risk overall. Mike, what are your takeaways?
Yeah, absolutely. I think risk assessment in every patient, start with the prevent risk calculator, realize its limitations in certain patients, borderline to intermediate risk, consider personalization of risk. That can be with an imaging test that is now recommended in the guidelines, particularly the calcium score. And when you get the calcium score, think about statins, LDL goals, and aspirin therapy. And we think about statins when the calcium score is positive, typically. When the calcium score is higher, lower LDL goals, and typically when the calcium score rises above 100, if the patient is in high risk of bleeding, you consider an aspirin as part of shared decision making. So, Chuck, I'll say thank you for this great discussion, and thank you to our listeners for participating in this activity. And please continue on to answer the questions that follow and complete the evaluation for this program. Thank you.
Thanks. Take care, all.